So, thank you for joining SOHO Insider for this special program focused on community oncology, where we will have a monthly discussion on relevant topics in the community setting. We will have a recording of the talk available on sohoinsider.com. Attendees may ask questions by using the Q&A, and I'll be sure to monitor those. While our invited speaker today, Dr. Manali Kamdar, will be discussing CAR T in the community setting. And I just want to highlight Dr. Kamdar is currently the director for the clinical lymphoma program at the University of Colorado in Denver. We share patients. She's also a key investigator in many of the practice-changing studies, including now having CAR T available in second line for our patients. So, Dr. Kamdar, it's my great privilege and honor to welcome you today.
Thank you so much for your kind introduction, and I am thrilled to kickstart this brown bag series. And I was assigned to talk about expanding access of CAR T cell therapy to outside of academic centers in the community. Overall, I'm going to provide a very brief highlight. I'm very certain that the audience here is already aware of all the wonderful outcomes that CAR T cell therapy has actually given to our patients. It's now time to take it outside of just select centers. Anti-CD19 CAR T cell therapy, particularly these three constructs that came out of these three pivotal studies, namely ZUMA-1, JULIET, and TRANSCEND, made axicabtagene ciloleucel, herein called axi-cel, tisagenlecleucel, tisacel, and lisocabtagene maraleucel, now called liso-cel, respectively, across these three pivotal studies, got approved in relapsed refractory large B-cell lymphoma after 3 lines of treatment. It was extremely reassuring to see that at the long-term follow-up, which was roughly 4 to 5 years across the 3 studies, that now there is a plateau that is beginning to emerge, highlighting that patients who have had been pre-treated with multiple lines of treatment, particularly immunochemotherapy, especially in the third line plus relapse refractory large B-cell lymphoma setting, about 30 to 40% of these patients can now be cured by CAR T cell therapy. And thus in 2021, all our algorithms really changed. Initially, after patient gets diagnosed with relapse refractory large B-cell lymphoma, we used to still go ahead and give them second-line chemoimmunotherapy. If patients demonstrated chemosensitive disease and were transplant eligible, they used to go to an autotransplant. But if they were refractory or not transplant eligible, then they used to be pivoted to CAR T-cell therapy. Now, clearly something that works when autotransplant fails should likely be moved ahead, and that's exactly what we found with some of these investigations into outcomes that we did in high-risk relapse refractory large B-cell lymphoma. So not all relapses are created equal. You can see this on the CORAL study. If patients had received rituximab primarily as their first-line chemoimmunotherapy program, which is everybody, these patients, if they relapsed within 1 year, their overall survival was quite dismal. Similarly, there was a meta-analysis called the SCHOLAR-1 meta-analysis that showed that patients who are primary refractory, patients who relapse within 1 year of having received an autotransplant, their complete response rate to subsequent treatment was only 7%, with the median overall survival of only 6 months. So clearly there was a high-risk subset that we had now begun to identify, primarily either patients who just never responded to frontline chemoimmunotherapy, called the primary refractory diffuse large B-cell lymphoma, or patients who relapsed with diffuse large B-cell lymphoma within 1 year of having received frontline chemoimmunotherapy. So we identified this high-risk subset, and 3 randomized trials were launched, primarily ZUMA-7, which compared axi-cel to autotransplant in this second-line high-risk relapse refractory large B-cell lymphoma setting, TRANSFORM, which did the same, liso-cel versus autotransplant in this high-risk setting, and BELINDA, which compared tisagenlecleucel to an autotransplant in this high-risk setting. In the interest of time, this is basically a snapshot across the 3 studies. There are key differences to highlight, but the primary endpoint across the 3 studies was event-free survival. And I think the audience here very well knows that BELINDA was a negative study. However, axi-cel and liso-cel were positive studies. Axicell as well as Lysocell both met the primary endpoint of event-free survival. You can see that the overall response rate with CAR T cell therapy was upwards of 80% versus only 50% with an auto transplant. Complete response rate was upwards of 60% with only 30% in the auto transplant arm. And then in terms of CRS and ICANS, which are the key functional toxicities that we see with CAR T cell therapy, grade 3 or higher CRS and ICANS or neurotoxicity was seen in 6% and 21% respectively in the ZUMA 7 study, and 1% and 4% respectively on the Transform study. There were key differences to highlight that on the ZUMA 7 study, bridging therapy with only steroids was allowed. On the other hand, on Transform, one cycle of salvage chemo was allowed. Crossover was not permitted on protocol on the ZUMA 7 study versus it was allowed on the Transform study. Now we have follow-ups up to 4 years across both of these positive pivotal studies that essentially made CAR T cell therapy the new standard of care and displaced auto transplant, which used to be the standard of care for almost quarter of a century in this high-risk relapse refractory setting. So with Axicell now at a median follow-up of roughly 5 years, you can see that the 48-month overall survival with Axicell was 54.6% versus only 46% on the standard of care arm. And on this study, Axicell provided a 27% reduction in the risk of death versus an auto transplant. There was no crossover permitted on the Axicell study. Then we had the same that was demonstrated with Lysocell at the 3-year mark. You can see that at the 3-year mark, the 3-year overall survival with Lysocell was 62.8% versus only 51.8%. This is despite a crossover of 62% of patients that crossed over after they did not have either chemosensitive disease with salvage chemo on the standard of care arm, or they crossed over after having progressed on the auto transplant arm. We now have 4-year data with Lysocell as well, and you can see that at the 4-year mark, the overall survival rate was high and almost equivalent to Axicell, upwards of 52%. A lot of providers ask me that what is the difference in getting Lysocell in second line versus third line? It's approved in third line. Maybe we can try chemotherapy in second line. And if the patient is transplant eligible, maybe take them then. But we do know that in this high risk relapse refractory diffuse large B-cell lymphoma setting in second line, which is primarily primary refractory, or patients who relapse within the first year of having received R-CHOP, you can see that if they receive Lysocell in second line, the 2-year progression-free survival is higher than if they were to receive Lysocell in third line. It translates for an overall survival at the 2-year mark to 95% with second-line Lysocell versus 78% with third-line Lysocell. So it indeed does make a difference. So I will say that although Lysocell, Axicell, and Tisacell are all approved in the third-line setting, in the second-line setting, especially in fit individuals who are primary refractory or have relapsed within the 1 year of receiving chemoimmunotherapy, CD19 CAR T cell therapy with either Lysocell or Axicell is now the new standard of care. Patient-reported outcomes, as you know, is a very important variable that's beginning to emerge in oncology. We want to know what patients actually make of their new treatment. And both on the Transform and ZUMA 7 studies, there were significant improvements in PROs with clinically meaningful improvements in quality of life for patients that randomized to CAR T versus an auto transplant. So at this point in time, Lysocell and Axicell are also approved in fit patients in the second-line setting, provided they are high-risk relapse diffuse large B-cell lymphoma. So clearly the next question is, what about patients who are transplant ineligible? And the pilot study actually looked at these patients who were not eligible for transplant. So they were unfit patients who received Lysocell in a phase 2 study called the pilot study. And you can see the overall response rate was high at 80%, and that was basically the primary endpoint. It was met, and more importantly, the median overall survival at the 24-month mark was not reached. CAR T cell therapy is also approved in other subtypes of lymphoma, primarily follicular lymphoma in the third line setting, relapse mantle cell lymphoma, and relapse CLL after they have been exposed to BTK and BCL2 inhibitors. So it's really important to really understand when and how can we get CARs to everybody and not limited just to specialized academic or specialized community sites. So the big question is who is eligible? And the one take home that I will say is transplant eligibility criteria is not the same as CAR T eligibility. If patient is transplant eligible, they are CAR eligible, but if they are transplant ineligible, that will not make them CAR ineligible. And based on who is eligible, we all really came up with a manuscript, a white paper here, where we looked at how do we take care of patients and how do we really get them to the CAR T site ASAP. I will say that nothing is technically making them ineligible, definitely not age or poor performance status or lack of response to chemotherapy. Sometimes salvage chemo gets given in the community setting. Patients have a response, and that patient then gets deemed as CAR T ineligible. We can do CARs if patients have progressive disease, stable disease, partial responses, or even a complete response. The same goes for impaired organ function. If patients have an impaired or a poor borderline cardiovascular function, pulmonary function, renal function, all of these patients individually, we have all taken these patients to CARs very successfully. So I would usually tell my community partners that if you think of giving GEMOX to a patient, I would think of giving CAR T. And we now know that CAR T in the third line as well as in the second line is given with curative intent. So patients in the third line, 40% who would have otherwise succumbed to cancer are now cured with CAR. In the second line, we are now seeing that signal in up to 50 to 55% of patients. Logistics. I think the biggest bane of CAR T cell therapy is logistics. I will say that there is something called the brain to vein time, which I will not take credit for that word. It was coined by Matt Lunning from the University of Nebraska. But I usually tell my community partners that if you think a patient is relapsing, just pick up the phone and call me, because it's so important to bring that patient in for a consult, because insurance authorization takes about 2.5 weeks. And then the patient gets on the apheresis schedule. After apheresis, the clock is ticking, the cancer is not waiting. As a result, the big question is, what do we bridge our patients with? I often think that if the burden of disease is usually just local and bulky, I use radiation a lot. But if the burden of disease is systemic and we are not able to quite just salvage them with just steroids, I would think at this point in time, there are novel agents like CD20 bites that we can give our patients, but even something like our GEMOX can often hold the disease quite steady. Toxicities, I think there was a lot of concern about CAR T cell therapy toxicities, and I'm going to show you some data that actually looks quite assuring, primarily around CRS, neurotoxicity, but the other toxicity signal would be around B cell depletion, because that's how CARs work. So there is inevitably hypogammaglobulinemia. Patients with an IgG less than 400 must be given IVIG prophylactically for at least up to the first 6 months post CAR T cell therapy. Risk of infection is present for the first 6 months at least, so making sure that they get adequate prophylaxis with an antiviral, anti-PJP is absolutely indicated, because infection is the main driver of non-relapse mortality after CAR T cell therapy. This is basically a great start to telling CARs can be done in the community. Dr. Yulia Linhares spearheaded this effort in the community centers, where outreach was the study where lisocabtagene was primarily given at community sites. And the take home is that we can do this, and we can do this very safely, and we absolutely will need an academic partner or a center that is larger than ours to continue to have the hub and spoke model to be able to successfully deliver CARs in the community. I think the biggest takeaway this year, or actually we are now in 2026, last year, was this comprehensive analysis of lisocabtagene maraleucel that was done across all lymphoma subtypes. About 1,500 patients were evaluated, half on clinical trials and half through a CIBMTR registry. And you can see that on this bar graph, majority of CRS and majority of ICANS happened in the first 14 days. And this clinical trial led the FDA to change the mandate, whereas you may have known that previously everybody had to relocate for 4 weeks to the CAR T site, and then they couldn't drive for 8 weeks. Now we have updated requirements. That has now been shortened to only 2 weeks at the academic site or the CAR T site, and the driving restrictions have actually gone down from 8 weeks to 2 weeks. It is huge in terms of impact for patients as well as their caregivers. The rest of the recommendations have remained the same, which is we still need to have 2 doses of tocilizumab available before infusion. However, certain things have certainly changed, which is the REMS requirement has been fully removed for CAR T cell therapy, which basically means that I think the system is now beginning to have trust in the construct that we can deliver this quite well, even in the community setting. So the big question then is, how do we expand access to community centers? I don't think I have the panacea to this question, but what I do need is, I think a lot of partnerships will be key, but also a risk adapted delivery model in the community. You don't want to take your highest tumor burden, your oldest patient to your first CAR in the community. You may want to kind of risk stratify them, develop standardized algorithms with regards to toxicity managements, early intervention pathways like telehealth, making sure your nurse practitioners, physician assistants feel quite comfortable taking care of these patients. Then there's obviously the hub and spoke partnerships that we talked about. Having a seamless referral to a CAR T site is absolutely crucial. If in doubt, the community partner MD or an APP has the ability to just pick up the phone and speak with the MD or APP at the largest center. I think a bidirectional communication is absolutely important to make this a success. It doesn't just go from academia to community, but also the reverse. So now we know that patients don't have to stay with us for the entire 1 month. What does it mean for patients to return to the community at the day 14 mark if they are actually doing fine without CRS, without ICANS? What we do here at the University of Colorado, we have a checklist. My nurse navigators basically transfer it back to the community center and say, these are all the things that we need to check. We are here. If anything was to go wrong, this is the number to call. And then the patient can be basically transferred back to us. Education, infrastructure, absolutely important with regards to targeted training, nursing support. Nurses have to feel confident about this. And then obviously the operational simplification will also be quite important in terms of streamlining everything, including the referral criteria. But I do believe that if you think that somebody needs SCAR, I don't feel like it's right to just look at the patient and say they are CAR ineligible. I think it's very important that a CAR T site make that determination, because you'd be surprised to see how many otherwise unfit patients could actually be successfully taken through CAR T cell therapy. So I do believe that the path forward is moving around from center-based excellence to like system-wide capacity. I think it's very important to measure our success by not about, who receives SCAR, but who can deliver it. I think it's very important to align every single stakeholder in this process, clinicians, payers, industry, as well as regulators. In conclusion, I do believe that the field is evolving. We have many, many new constructs coming down the pike. So I think it's extremely important that our community have every way to feel empowered to be able to deliver these immunotherapeutic approaches. I also believe that CAR T cell therapy should be defined by biological eligibility and not by geography. I do believe expanding community access is the most meaningful innovation that we can do for the next decade for our patients. With that, I'm coming to the end of this talk. Happy to take questions.
Thank you, Dr. Kamdar. And I really appreciate your insights and your expertise in an area where we share similar thoughts. We got to figure out how to safely get this therapy to community sites. You and I share patients. I recognize it's quite easy for me to reach out to you directly, and you do what you say, and that you provide your cell phone, and you're very receptive to people reaching out, and you're very quick to respond, and your team is phenomenal about getting to us and to patients very quickly. How do we take that model and reproduce it in other places where maybe folks don't have an established working relationship with their referring center? What are best practices there?
I think it's very important that, not everybody follows NCCN guidelines. I think it starts with that. Sometimes there are pathways that certain community offices have to follow, and you would be surprised to see that in the pathway, autotransplant is still listed as an entity. I'm not taking away the power of autotransplant, but I do believe that CAR T cell therapy should be offered to the right candidate, which is the high risk second line relapse DLBCL based on the pivotal studies. I think changing those pathways is the first thing. But I think a lot of it will also be kind of thrust back onto the CAR T site, where we have to be also encouraging our community partners and basically checking on them. So I will say that, it's amazing after you have come to Colorado, what level of care and how it has become elevated in your region, just with your presence. But a lot needs to be done in other sites, which are also catchment areas for Colorado. Like we are planning to get to New Mexico and Wyoming and North Dakota and South Dakota. These are our catchment areas. And we have very many physicians who have our cell and we have the ability to just get there. But maybe there could be a way where, we can create a kind of when I talk about the hub and spoke model, I also feel that not just a CAR T center, but somebody like your site, someone in the even remote areas can actually just call you and say, what shall we do? There could be multiple ways and permutations where we can reach the right provider at the right time. The right time is just so crucial here.
Exactly, as soon as possible. I think the other thing you do very well are telehealth visits where you're very quick to get on a video or a call with patients to spare them traveling. And again, if we could somehow influence practice and policies out there to make that more readily available. I think the other key thing that you pointed out is that the toxicity is much more manageable and probably less intense than most worry about. So, how do we also communicate that message? Because there's still a lot of fear about just the ability for people to tolerate it. So, how can we address that barrier?
I think there are many ways to doing that besides, of course, what you are doing with the brown bag series and getting the messaging out. I think getting the messaging out multiple times over is just so important, not just for our community partners, but also for our patients, because social media is just sometimes extremely devilish in terms of what they hear. So when they get on a call with me, they already have made up their mind that it's going to be very bad. And when it is so boring, they are able to then relate to their peers that it actually isn't that bad. But when we look at social media, we also have a lot of people who have gone through that experience negatively. There are fewer people who have experienced it positively to actually shine it like the way it is. So I do believe that there is just, a demon that we have to deal with. But there are many advocacy groups, the not-for-profit organizations like the LRF, the LLS, that are constantly sending the message out that we need to make sure that this message gets out, that toxicity, which once used to be absolutely very severe because we didn't know how to manage it, now we have like standardized algorithms in place that it is absolutely doable.
And I think I'll make another plug for you and what you're doing to help address this is that as we see more patients going back to their originating site within the first few weeks, there is a need for folks that maybe have less experience with these therapies to understand what to watch for, what to do if that were to happen, and what sort of testing and frequency of visits should be done. And so I think you're working on a potential sort of white paper to kind of walk centers through that. So do you want to kind of highlight some of the
Yeah.
work being done
I
there?
think all of us got together to come up with a strategy to outline how best to really help our community partners feel empowered. And we usually are recommending a phased approach where initially maybe we get them out at the day 25 mark and then see how they're able to manage the cytopenias. Or once the community partners are ready at the day 14 mark, I think it's very important that GCSF gets authorized, the prophylactic gets given. If patients need transfusion, then transfusion is ready. But if the community site is not able to do daily transfusions, then in that case, maybe it's beneficial for the patient to stay on board with the treating site for a little bit longer. So yes, that white paper is coming out quite soon. Thank you for that reminder.
I said, I just really appreciate any opportunity I have to pick your brain, and I think just your insight and sort of your impact on the community is huge, and will only continue to be even better as you get better at this. So again, thank you for your time and your expertise. And thank you all for joining us. Please join us for our next meeting, which will take place on February 11th at 2 p.m. Central Time. I'm going to have the pleasure of chatting with Dr. Tara Graff, who's from in Des Moines, Iowa, and also has a unique perspective for how we get some of these novel therapies into the community. And we'll specifically be discussing implementing bispecific antibodies in community practice. Thank you very much, Dr. Kamdar.
Thank you very much.